for free key newborn screenings activity that's happened when a child is born, the blood spot that she was talking about. And there's also the pulse oximetry as well as the newborn hearing screening. So yeah, let's dive into the pulse oximetry screening and how it related to the birth anomaly surveillance system, public health program. So pulse oximetry screening is a test that measures the blood oxygen saturation level and heart rate. It is a key indicator for the critical congenital heart defects. It is for adults, it is a clipper thing on your on one of your fingers. And for babies, for newborn, it is a sensor placed in the baby's right hand and the foot. Kind of like the picture I show you in the beginning. Here, like there will be something bundled into the sensor. The procedure is really quick. It's not invasive and it is painless. This test is conducted within at least after 24 hours of age and before the baby is discharged. And if the baby is discharged early before the 24 hours, it should be done as late as possible before discharge. This is a test being added as part of the US recommended uniform screening panel in 2011. It is actually really recent. It is one of the first easy to conduct tests to test for oxygen level and indication for any heart diseases. And if there's low blood oxygen level, then the baby will probably be referred to conduct more tests like echocardiogram or go to the cardiologist for further testings. And yeah, so as I mentioned, it tests for CCHD, critical congenital heart defects, before they show any signs like baby turning blue. That would be a little too late. Congenital heart defects account for about 30% of the infant deaths due to birth defects, and about 17 to 31% of all of the congenital heart defects are critical congenital heart defects. And a lot of times it will require some kind of intervention, a surgery, to close up some of the holes in the heart and allow for the baby to grow. And how does that relate to our birth anomaly surveillance system? The test, we don't keep track of that, but FAST, we recognize that there's knowledge gaps of information about different birth anomalies. We actually work pretty extensively with some of our colleagues at OHSU in their pediatric cardiology department to learn more about the pulse oximetry testing and how is it done, and provide some actual data to compare before and after the implementation of that guidance, that mandate in 2011. So it is a program tracking a lot of heart defects, but also many other birth anomalies. There's no legislative mandate. It is a passive surveillance system using administrative data, so it's fairly low cost program. We are a pretty young program. We are one of the last 4 US jurisdictions that established this surveillance program. So for the history, I'm not going to bore you to it, but basically back in the 2000s, we have extensive discussion about like building this program. There's more conversation about fetal alcohol syndrome at the time. And by 2008, EPHD, Environmental Public Health Tracking, has interest in looking into environment and birth anomalies. So there's some partnership work there. And by 2013, we're able to submit our data to our National Birth Defect Prevention Network to conduct some collaborative work nationally. And 2016, we were funded by CDC first time. But unfortunately, we only got the funding for one cycle, and it is a really competitive funds. It's only like 12 out of 50 plus jurisdiction that got the money. So it ended in about 2021. And what does a program do? We mainly do surveillance. We established the surveillance system because we don't know much about the information in our states. We want to have some baseline information about the prevalence. We want to be able to monitor some patterns. So that's why we have that. We also want to be able to disseminate the information. We want to, based on the learnings from the surveillance and national scientific knowledge and prevention information, we want to educate the public about it. And last but not least, but we want to build capacity via partnerships, both internal and external, just to gain knowledge about these newborn screenings and also educate family and linking family to resources. So this slide highlights some of the more specific activity we perform in our program. So some of the data elements on the more of the left side. And then we have also like identifying disparity, targeting prevention and outreach, understanding the impact, producing educational material and strengthen our collaborations. And how does it work? Our system, as I mentioned earlier, is a passive surveillance system. We use administrative data. We have a combination of data source, such as birth certificate, death certificate. Is it another click? Ah, there we go. Birth certificate, hospital discharge data, and Medicaid claims. Those are initial data sources. We added the data source for death certificate and newborn hearing screening later on to increase the scope of our work. We are tracking babies from 0 to 5 years old because some of these, even though as a congenital conditions, they occur or discover or diagnosed later in life. So we have a fairly long tracking period. And the program grew pretty quickly. We grew from tracking initially from 12 core birth anomalies to about 50 now. As I mentioned, we also added the data source for triangulations. So here's the major birth anomaly groups shown. We track things from anencephaly, spinal bifida, and central nervous system, eye, ear, cardiovascular, as I mentioned, like hypoplastic left heart syndrome, or orofacial, gastrointestinal, genital urinary conditions, musculoskeletal, and chromosomal. So in the map on the right, it shows some of these conditions we track. I think they're all there, but I'm not even sure at this point. So what we learned from our program, we have about 40,000 births each year. Roughly 2,000 infants have a birth anomaly that we track annually. And based on our work in the last several years, we learned that family do not prefer to use the term they prefer to use the term birth anomaly rather than birth defects. Birth defects is more of a medical system stamp terminology. So when we work with family, it is important to be mindful to say something like birth anomaly conditions or just check with the family how they prefer their kiddos' conditions be addressed. We are doing some data dissemination work. We're in the work of building some data dashboard that hopefully it'll be on our website one day. So this is work in progress. We also aligned some of our program goals to Title V work to promote healthy pregnancy. And that piece has been also very helpful to combine our education dissemination effort, social media work to the public. For example, have regular visit with healthcare provider, avoid harmful substance like tobacco, alcohol, drugs, make sure you have healthy mind and body, also reduce risk of infection, um, maintaining basic hygienes, as well as also taking 400 micrograms of folic acid every day. So those are some of the key important message that we use to promote healthy pregnancy and healthy birth. Some of the limitation to our program is that we don't have really stable funding. So and we don't really have a state mandate to run this program. So we're limited on a budget, and that's why we have a passive data source. Um, and also we cannot like do any follow-up work with families. So that's one of the biggest barrier we have. And this is like exactly where we need to do a lot of partnership. Early on and still ongoing relationship we have is the Family Health Information Center. They are with the Oceans Group, the Oregon Center for Children and Youth with Special Healthcare Needs. And they are able to connect family to resources and support. They are a team of parents. They all have children with special needs, and they have experience navigating different Oregon healthcare systems. They know about community system, educational systems. So they have helped people work through challenges along the way. And each state has a family health information center, and that's funded by the government. Some of the things our Family Health Information Center do in Oregon. As I mentioned, they provide one-on-one support. They have toolkits. They have free trainings. They do table talk, kind of like a focus group. Like I think a recent one, they gather fathers and they want to have like uh, conversations about that. They also have like tip sheets and resource. Our group work with them closely to develop like a one pager for each of the birth anomaly we track, providing resource and website linkage connections to other families that might have the same conditions. They also do more than that. They have done a lot of work like healthcare advocacy, transition from children to youth and adult life, because now a lot more children live longer age than they used to. Um, and again, we had some one page profile. They also did something called Hero Kits that did one page profile that family can set up and provide medical team, like in an emergency situation, like, oh, my child might move a lot or sensitive to light and things like that. So they have one pager profile that family can fill out in preparation for any emergency medical setting or medical visit to make the experience more pleasant. So this is one of the one pager I was talking about that focus on hypoplastic left heart syndrome. So it provide family some information what it is and resources to more national groups and family stories and so on and so forth. Mhm. And we also have partner with a lot of other groups. We work with CDC, we work with Public Health Environmental Tracking, March of Time, 211 Info, WIC, OHSU, as well as NBDPN, National Birth Defect Prevention Network, to promote some of our educational work and also share challenges with our surveillance work. So that's something to highlight. Another piece I really want to highlight with y'all related to a BAS program is folic acid and neurotroop defects. Um, oh, I have a typo there. So it is recommended that 400 micrograms of folic acid every day can reduce the incidence of neurotroop tube defects such as anencephaly and spina bifida. Those are very deadly birth anomalies that a child can die from early on in their lives. So that will require surgery to fix. And some of the cases of anencephaly, the child didn't even born, like the child become a stillbirth. And so it is important to have, it's nice to have that intervention available to us. In fact, this is a mandatory, there's a mandatory fortification of grain products back in 1998 on grain products such as cereal, flour, rice, pasta, you might all be familiar with. And so that helps increase the folate consumption of a population. We do notice a disparity in folic acid intake that is associated with socioeconomic status based on some of my analytic work using PRAMS data. And in 2016, we're noting that FDA has allowed voluntary fortification of corn masa flour. It is not a mandate like the one for grain products back in 1998. So we are still seeing some discrepancy in a cultural population, for example, or still have issues with socioeconomic status, perhaps due to access to folic acid or knowledge of folic acid. So that is a message that we would like your group to be able to help us and partner and share with families about. So how can you help? Help them understand different newborn screenings that will happen, and so they know what to expect when the child is born. Promote folic acid supplement for people who are pregnant or planning to be pregnant to prevent new or tube defects, and help family know about our programs if they need help. So I'm going to fly through this other program fairly quickly, hopefully. Newborn hearing screening, and it's tracked by the Early Hearing Detection Intervention Program, EHDI program. The screening looks like this. There's like little headphones and little sticker sensor on their head. It is also non-invasive, it's really quick. Congenital hearing loss is fairly common, about 3 in 1,000 birth. And a lot of the babies who are born with a hearing loss do not have any risk factors. They're invisible, they are hard to know unless there's specific testing, and they can be addressed best when it's early on. Because when we address early on, they can help develop skills related to communication, cognition, physical, social, emotional, and self-help. Like it's all connected to your ability to receive input and express yourself. Communication is a spectrum, so it is important to screen that, because like sometimes baby can hear some degree or some level of sound at different decibel perhaps, like, and but it doesn't mean they have like normal hearing. So it is important to address any differences and have that follow up and be noted. And family can choose to expand the horizon of how they want to communicate with their child in different form, whether it is visual communication like ASL or audio communication with help of hearing aids and things like that. So our program started back in 1999. It requires hearing screening for all baby born in hospital with at least 200 births, and reporting to us to the EHDI program within 10 days. So that's all I'm going to say here. EHDI is a national and state-based program. It is housed in OHA. We have a really small team staff, about 5 or 6 people, and most of us are shared between different programs, like me. We aim to identify children who are deaf and hard of hearing and refer them to supportive service like early intervention for ongoing growth and development. We monitor hearing screening results. We monitor the follow-up diagnostic results and also enrollment in early intervention service. We also collaborate with other partners like community-based organizations, with other state programs, and such as like the home visiting programs and other state EHDI programs. We track people 0 to 3 years old. We track all babies born in Oregon as well as baby born out of state to Oregon resident or they move in. So our program has a 136 goal, and it is to screen all babies born within 1 month. And for baby who did not pass this screening, have them have a complete hearing diagnostic service done within 3 months of age. And for baby who are deaf or hard of hearing, enroll in early intervention within 6 months. And we know that when intervention is done early on, there's a higher level of kindergarten readiness by age 5. And what we learned from our work, over 98% of Oregon babies are screened every year, and about 1,200 did not pass the screening, and half of these are WIC babies. A lot of them do get follow-up diagnostic, and overall, we have about 85 babies who are deaf and hard of hearing found in Oregon every year. But also we have the similar situation as Jacqui. We have lost to follow-up, and over 200 baby each year do not receive further testing, and we couldn't get hold of them. About 75% of the baby with hearing loss are enrolled in early hearing and early intervention program, and about half of them enroll within the 6 months benchmark. And some of the support we provide, we follow up with providers and families for documentations. We also partner with other programs such as the Public Health Lab, home visiting program, WIC, DMV, Medicaid, to enhance our follow-up. We also facilitate early intervention enrollment and refer them to parent support program, like Guide by Your Side. And we relied on our partners to help these families. And that's where you come in, and you can help them know about our programs, know about the screening, and flagging families who or any community needs to our team, and we can provide more support and continue to offer high quality and timely service so we can get these babies screened in time. So yeah, it's right at 4.
Perfect timing, Vivian. Thanks so much. Does anyone have any questions for Vivian? Well, there is one in the chat from Julie. I don't know if you see that, but she says, given that a recently passed California bill requires fortification of corn masa, do you think that will help? Given they're such a big market and manufacturers need to change products to meet their requirements.
Absolutely. I mean, I do think there's a need there, like because it's just a voluntary recommendation right now for the corn masa product instead of like for other green product, it is a mandate. I do think like having that kind of legislature would definitely help.
Are you planning to make a push for that for the not you personally maybe, but push for that in the legislature? Alabama has passed one too. It'll be a little bit before it comes, but we don't want to be behind.
That's good to know because I'm more data focused and less policy focused, so it's actually really important to know about it. I definitely bring it up to my team, my manager, and I don't know if there's any potential champion out there.
Well, we seem to have a lot of, well, maybe not a lot, but we have quite a number of state legislators who seem to have an interest in nutrition and babies. Just saying
That's a good plug.
that that's something they could look at other legislation. And then, Mexico has had requirements for fortification for quite a while now. It's not terrifically enforced, but you could also look at that.
Well, and also if they were able to convince like manufacturer to do that, it should benefit like all states as well. So, I mean, that might be another way we can all help, like as private citizens, we can all help promote that to our legislators.
Not advocating, just educating.
Yes.
I know we're a little bit over, but does anyone have any other last minute questions for Vivian while we have her? Great. Well, thanks so much, everyone, for joining us. Thank you so much, Vivian. If any questions come up after we close today, I'll be sure to get them.